I haven't got any slides because my slides are on a computer that didn't recharge over lunch. So I'm going to just talk verbally, thank you, as to what we do. So I'm in a very different situation from Helena. So I'm a reproductive endocrinologist, and I work in two places, and this may be more similar to you in India. So one is I work in a public hospital where I do one afternoon a week reproductive endocrine PCOS clinic, and as a result of that I will see people who really can't afford very much in the way of treatment, or they have medical conditions, abnormal bleeding, gynecological conditions, etc. In the public hospital, we are completely banned from doing any IVF or IUI. So you have to have a license in Australia to be able to do IVF or IUI, and our state has decided that no public hospital will be allowed to do IVF. You cannot have pickups, you cannot do IUI in the public hospital. What I can do is do an assessment of patients. We can get surgery done, so we can do hysteroscopies, laparoscopies, hysterectomies, any advanced surgery. We can offer clomiphene and letrozole, metformin, and recently we've introduced ovulation induction with FSH. So we get a lot of patients sent to my clinic where they're wanting to get pregnant and they're going to get pregnant on oral drugs. So one of my fellows, Vicky Nissenblatt, has set up a questionnaire which was utterly based on evidence-based guidelines. And so every patient fills out a questionnaire before they come. We have a standard assessment of those patients, again based on the guidelines, which includes the glucose tolerance test and lipids and emotional well-being test and things like that. And then we work out what we're going to do in terms of fertility or metabolic. So if it's metabolic, we'll do all the right assessments and we'll give them advice about what they can do, and then we will send them back to the general practitioner and see them occasionally after that. So unlike Helena, I have no dietitian, no psychologist, no laser therapist in my clinic because the hospital won't pay for that. Helena is in a situation where she has got a big grant from her state government to do many of those things. So I think I'm more like your situation where you don't have all these ancillary things, and if somebody needs dietary advice, they usually have to go and see a private dietitian somewhere and get going on that way. Other people have to go and pay for their own laser. So we're quite limited in what we can do like that. But in terms of the fertility side, the hospital has been very good, and they've given me a full-time nurse who we've trained up in fertility. And so she can do ultrasound scans, she can monitor patients, she's allowed to order bloods. And so I will set up a cycle and say we're going to do letrozole on this patient, and then the patient will stay in touch with the nurse. The nurse will organize bloods when she wants to do them. She'll do ultrasound scan, and she can phone me at any time, wherever I am, and say, look, this lady now has estrogen of this level and a follicle size this size, what do we do? And then we make our decision. So we've done that for maybe 3 or 4 years for metformin, letrozole and clomiphene. And about 6 months ago, I decided that I'd train her on doing FSH ovulation induction. And she's done a great job. She has been to the private clinic to learn how to do this. We were given tremendous opportunity for her to spend a couple of days in Melbourne at a clinic run by John McBain, who many of you may have heard of, in the public system, and she learned how to do scans and to give instructions to patients. And so now we're able to do FSH ovulation induction in a public setting. All the drugs in the government system are provided virtually free of charge. So you could have a whole ovulation induction cycle for less than $40, including all the drugs, the scans and everything in a public system. So it means that for many people who can't afford any private care, we're able to do that with a combination of a doctor who comes once a week but is on call most of the time, and a nurse who's there 5 days a week, who is reasonably well trained, can do scans and can make decisions. So that's what we've done in the public system. What we need to do now is expand it much more so that we cover many more of the metabolic, dietary, psychological and cosmetic issues that Helena's got. So Helena doesn't have quite the ovulation induction facilities I've got. I haven't got the medical facilities that she's got. So between us, we need to kind of work out how we can get this across the country so that we've got all of it. In the private system where I work, we have an outstanding group of people that offer very, very high quality IVF, IUI, ovulation induction. And what we insist in the private clinic is we will not see patients who have conditions that are not infertility. So if patients have got metabolic problems, they've got to come and see me in the public system. If they've got infertility and they don't want to go to the public hospital, they want to go privately, then they'll come and see me at a PCOS clinic there. And I have a nurse who's worked with me for 30 years who is superior to me in ovulation induction. She is absolutely brilliant. And the most difficult PCOS patients, the ones that overstimulate or never stimulate, she has got such a strong track record on. And, she can change gonadotrophin doses and do subtle changes. She's a qualified ultrasonographer as well. And so when I see patients and decide what treatment they're going to have for infertility with ovulation induction, I hand them over to Paula, my nurse, and I will often hear nothing again until I'm doing the scan for their pregnancy. I totally trust her. And I think one of the lessons that I've learned going throughout Asia for the last 30 years is that all of us need to use nurses better. Nurses have often had a very poor status in our communities, and they are incredibly intelligent and well trained, and I believe that we should really be equipping our nurses. And maybe we as a PCOS society in India, you need to run a course for nurses if you haven't done so already, rather than for doctors. So with Paula, I can do any difficult ovulation induction. If we decide that ovulation induction is not appropriate, I have a group of people who've been trained in vitro maturation. So they've been to Vietnam to see Dr. Lan, who is probably the top person in Asia other than one person in Australia. And Dr. Lan allowed them to do 30 pickups in 2 days for IVM in Vietnam. So we are able to do IVM. We don't do it very often because our patients often prefer to go through a full stimulated IVF cycle. But we have that facility. We have superb IVF facilities which are relatively inexpensive. We've got very good freezing. We've got all the things you've got. But we only put one embryo back. And so I'm very confident when we get a patient with PCOS for infertility, whether they're in the public system or the private system, we can look after them. What we do is if a patient is in the public system and needs IVF, we have a system where we reduce all the costs in the private system. So the patient will say, I want to be with you, and I'll give them an appointment in the private system. We reduce many of the costs, and so they're able to go through relatively inexpensively. So my setup is not as well developed as Helena, because it's very much me plus 2 nurses and a fellow that have got this going. We need to develop it much more in other hospitals and to have the other facilities such as dietitians, laser therapists, psychologists. But I think you can see through Helena's Melbourne approach and our Adelaide approach that we may be able to work to some sort of synthesis whereby we can offer PCOS services to people around the place. In Australia, the general practitioner or primary health care physician is the most important person because they see all the patients. You cannot see a specialist in Australia unless you're referred by a general practitioner. And so we have to spend a lot of our time educating our general practitioners, and then it means that once they're educated we can send our patients back and we know they're going to get good care. So part of our guideline development group is to make sure every general practitioner who's interested knows about the guidelines and what they can do. So I think, Helena, does that cover the main things that we need to do? So I would strongly suggest that if you can set up a PCOS clinic, if it's in the public system, and I think many of you do work in a public hospital at least for a couple of hours a week, think of whether you could set up some sort of clinic in that situation, and then also in your private clinic set aside maybe an afternoon a week and advertise and differentiate yourself as being a PCOS specialist and try and practice good quality medicine there. So, Helena, do you want to come up and we can answer questions if there are any? Has anyone got any questions? Does anything exist do you have anything like this going in India? Would anyone like to share their experience of PCOS clinics?
There is a PCOS clinic set up by the National Institute for Research in Reproductive Health, which is affiliated to the Indian Council of Medical Research. They have set up a center in Mumbai and they deal with patients who come from the public sector. So it's a sort of a free complimentary clinic for them, and they do have support groups there. They do have they refer them to the specialist whom they need to be referred to, and they run it similarly, and it's mainly in the public sector. Now when you go to the private sector, the question is that there are many people running PCOS clinics, but how organized they are, I'm not sure. The concern we have is that who becomes the primary person to whom the patient goes. If a patient goes to a gynecologist, now for her to have a specialist in her own clinic available to see the patient may not be practical. It would probably run as a once a week clinic wherein the specialist would be available. But as Helena said that you will probably deal with them directly and refer them only when they need to be referred to. But that means the patient goes into the same sort of building or same floor, or do they have to go far away? So the concern is that if it's a paid clinic, it's not very economically viable. That's the problem. So how does one run it economically if it's going to be in the private sector, and if it's run in the public sector, all the specialists are not available at the same time?
So just one comment on that is that one of the things is obviously not for ovulation induction and for fertility treatment, but for most of the other dimensions, if you have a well-trained team, then they should be able to deal with all the issues, especially if you've got very simple resources. So we give a lot of the resources to women before they come. We send them information before they come. We also send them a questionnaire on, one of the most useful I find is the one on hirsutism. And we were talking about this before. I've been looking for my copy of the questionnaire, and I'll send it to you, Duru, because some people asked. But we send them an email link, or they can do it on their phone beforehand. 95% of the women do it before they come in. And the main objective of those is that it actually makes the history taking really quick. So most of the questions we would ask are on the questionnaire. They click on the link, it goes straight through to the history, and we ask them things like, what is your most important problem? And they have to think about it before they come in. And if they say they've got hirsutism, they self-score their hirsutism We give them the Ferriman Galway, they score it themselves, and then we ask them questions like, does it stop you wearing clothes that you want to wear? Does it make you worry about yourself? How often do you think about it? And there's a very standardised questionnaire, and without exaggeration, I can read the information the women fill in, which is printed out in a standard format, and the results of their surveys, and it would save me about a 40-minute history. So that can be done very quickly. It's the same standardised format every time, and it also means that women have thought about what their main problems are. So we can go straight to dealing with those main problems. Because we've got all the resources, which you've got really good resources as well, and hopefully with the guideline you'll have a few more. And again, that makes it much more efficient, that women get the information they want. You don't have to one-on-one go through everything yourself. And in fact, we'll often give them that and say, next time we'll go through your questions when you've read it. Because otherwise you spend your time answering all of those. But I think the main thing I would reflect on is that, with the exception of ovulation induction, most of your team should be able to do most of it without having 5 people in the room.
I think funding in the public system, I work with a group, I think there are about 20 gynecologists, most of whom are part-time. There are probably only about 5 that are full-time involved. And they want me there because I'm the only one who understands about reproductive endocrinology generally. So prolactinomas, congenital adrenal hyperplasia, Turner's syndrome, those sort of things, they all want me to see them because they don't feel confident about them. They don't want to send them off somewhere else. So they want me for certain things. So part of my trade-off is I say, if you want me, this is what I want. And I want a dedicated nurse, and I want... So for instance, the other day I was examining a male, because we get males coming to our gynae clinic, and I said, where's the orchidometer? You know, that bead. Oh, we haven't got one. So I looked up on the website, and to buy one was about $200 US. And I said, this is ridiculous, they're not going to pay for this. So I went to the senior nurse, she said, I'll buy it for you, we've got money. So because there's the spirit of us offering something, they're happy to give back to us. I don't do any surgery in the hospital, so that doesn't divert my time at all. And I think they're just very happy to... The nurses get very excited when they see what we're doing, you know, because they see what the other gynecologists do and that they don't spend very much time assessing, and they don't know how to do ovulation induction, some of them. So when they see patients come through and get pregnant and that sort of thing, they're very excited. So for me, there are 2 keys. One is my senior person who's in charge of the whole clinic is very positive towards me. He wants me to stay, he wants me to work there. And then the nurses also like me, and they want to help me. So I think if you've got the senior doctor and the nurses supporting you, you can almost get anything done.
But just on that, the thing that is similar between the 2 services is our nurse does a lot of the work. So she does the pre-workup, she sends the information out, she does the education session for the women at the start of the session. So again, it just saves a lot of time, so you can be really efficient if you've got a nurse who can do quite a bit of it for you.
Just wanted to ask, how did you spread the information to the patients
They
about the clinic?
Yeah, they did that. So our support group has a Facebook page and a website, and it just went viral.
Just like that.
Yep, in fact, much more effective than...
Nothing like print media, no newspaper ads,
We
no
didn't have
radio
to.
ads.
We could have, but we didn't have to. Oh, we also were a little bit clever in our case. We got our health minister to come and announce it. We invited them. She's a woman. It's women's health. So she came, and of course the media came with her. But we were booked quite solidly before that, just because they put it on Facebook. And what I didn't mention, which I think is really important, is we didn't design the clinic, the women did. So we got them in a group of 8 or 10 women as a focus group and said, what would you like it to look like? Who do you want to see? And it was them who said, we don't want to go and see the gynecologist, the endocrinologist. We actually just want 1 or 2 people, and we're happy to read the information. We don't want multiple healthcare providers. was one of the reasons we got the laser is we have a very proactive transgender community in Australia who were doing a lot of lobbying with government and wanted to have access to free laser, and all of a sudden they got it. And I went to the health minister and said, oh, no, you don't. 13% of our population have had severe hirsutism. It's bothered them their whole lives and they can't get access. And the transgender community have gone and knocked on your door and said, we want laser hair removal. And you've said, fine. I said, so we'll manage the transgender laser service for you, but we want the laser for the women with PCOS. And we had it within 2 weeks. So we were slightly opportune. But I just think that if you're doing it in the public system, you need to be really efficient and have nurses and education resources and get the women to do the work themselves with their questionnaires.
I also noticed about 10 years ago that the patients knew far more about PCOS than the doctors did. So the patients were going to the doctors, general practitioners, and saying, I want metformin, or I want this, I want my insulin checked, I want glucose tolerance test. And the doctors didn't know anything about PCOS other than Stein-Leventhal that they'd learnt in medical school. And so when our evidence-based guidelines for Australia came out and we started doing the translation, the doctors started to realize that this was a big deal. They needed to know something about it. And so they learnt that there were resources available. And so many of our GPs are very interested in PCOS, and if it's ovulation induction, they'll refer them in, but then we send them back again once the patient's pregnant. There are a lot of doctors who have no interest in PCOS, and so to have a clinic that does PCOS, they're very happy. I can get rid of my patient to this clinic. So I think there's no problem getting patients to come because they look on the website, they find your name, and then the general practitioners either refer them there because they want them to get more help, or they refer them there to get rid of them from their care. So I think it's quite easy to get patients.
In South Asia, we do not have as strong a network of general practitioners as like what Australia has. We have a smattering of private GPs, but no state-funded GPs, and very often the private chambers of specialists really give out a GP care.
So it's the same as in the US. So the US, the primary care provider for women's health is a gynecologist.
Yes. In that context, I mean, the way I see it is there is the screening and diagnosis to follow up and a care plan throughout the life cycle. So in those terms, how do you see your model fitting in to our kind of rather chaotic model where patients do doctor shopping? I mean, they might be well versed with the internet, but they would change their doctors and not tell the second doctor that they saw the first one. And the fact that you have the sort of a model of care that will be fairly uniform.
I think it's a difficult problem. So for countries that do have a good primary care system, there is evidence they provide better care, but I mean that's not going to resolve the problem. The US has the same problem, and then the pressure is that the gynecologist really does need to take their primary care provider role. But we're hoping our aim is to make it as simple as possible to provide the best care, to make it as efficient as possible to provide the best care. And as Rob said, there's a lot more of this that can be done by the nursing staff. But the main idea is that we're going to give as much information directly to the women as possible so that they become the primary coordinator of their care. For example, they'll get reminders that, you're due to have your glucose screen, or you're due to have your, so all those sorts of things will come up as part of their care, so if they're using the app or the other resources. So I don't have a specific answer in your context, but I think it's more challenging because gynecologists may be less willing to look after all the components, but if we empower the women, maybe that will happen.
I just wonder, is it possible for the PCOS Society of India to have accredited courses where you give us a stamp of approval that you've been through this quality of training and that you are keeping going with continuous improvement, and that people can then use that stamp on their card or on their website. I'm sure this must happen in many other aspects of medicine. But if you could somehow control that.
We do have an online course available for doctors. We haven't yet set up for the nurses, but probably that could be our agenda for this year. But we have developed 6 modules actually, and they are all online. We made about 3,000 hard copies which were sent out to many doctors all over the country. But everything is available online. People can go online, download the courses, read it, and then what we are going to do is once they've done it, and then we are probably in the second week of April, we are running a sort of not really an exam, but kind of a program wherein they will respond to questions, and if they get more than 75% correct, they would get the certificate of, what would you call such a certificate?
We would then call them accredited modules. So they do accredited training modules.
Right.
And yours are exceptional. I had a look at the book last time I was here. The only difference is that as they go through the online modules that we've developed, they have to do the quizzes and tests as they go.
Yeah.
No one has to mark them. It's an electronic thing. If they don't get that right, they have to go back and do that section. So that's the only difference. But by the time they come out, we can then list them as a provider who's done training in that area.
So that's what we propose to do, call them as accredited courses from the PCOS Society of India. So soon we'll be announcing this to all the members, that those who would like to take the course, and then hopefully during the conference we'll distribute the certificates to the people who have got it, and that probably will give more visibility to the course. And this year we have done the basic, all the modules, but next financial year we'll be doing the advanced modules. But I think doing the modules for the nurses is a good idea.
It's probably a good idea on your website to list all the people who've passed.
Yes.
Because there'll be many other people who claim they've passed who haven't passed. And then it means the patients can go to your website to check that they actually are authentic.
Yeah, we also have a patient group. Actually, this is a website which we have set up called Conquer PCOS. This is done in collaboration with the PCOS Society of India. It doesn't really belong to us, belongs to another organization, but we have been their partners. And it's doing very well. We've had more than 50,000 hits in the last few months, and it's got a PCOS tracker. It's got a nutrition, diet, questions answered. There's a lot of blog support group going on. I mean, there's a lot of activity on it. So question is, people are happy to look at it, but our challenge is not only the people who come to our clinics are not all speaking English. So many languages in the country.
So Dura, at my local hospital, we have 81 languages, so I can relate to that.
So it's a little bit of a challenge, yes, but I'm sure we can look into it.
Yeah.
Thank you. Any questions from the audience? Yeah.
Is there any way we can access the PCOS questions?
Yes, so I'm going to send them to Dura. I thought I had them on my computer, but I don't. But I'll send them to you, especially the hirsutism one, and then you can adapt it for your population. We actually get them to, so we email them before they come into the clinic, and they enter I'm sure you can do this in India. All the people who do my IT at home are all from India. But you can just set up so that you send them the email link, they link on it, and they just enter their data, and it all comes in. It's all just printed out for you. It's quite an easy system. And it's a generic available software. But it saves dramatic amounts of time, and you can standardise the care, and the data is all collected, and most of the data collection is done by the women. So it makes it much easier. But one of the things that might be useful, Duru, that may help, is once we get that core outcome set sorted and the international data hub, then we'll make that available through the society, and anyone who wants to enter their data then can do that. And so we're supposed to be talking about research next, and one of the things we could do is with your support group, Conquer PCOS, we could have a look at what we've done in other countries. We've just finished in Mexico, and we've done most continents now, but it would be really good to work with your support group.
That would be nice. Yeah. We'll be happy to do it.
Mm-hmm.
Could I perhaps ask Chandrika, would you like to share what your clinic looks like in Colombo? I mean, do you have a PCOS clinic, or is it just part of your general endocrine?
It's actually a part of our general endocrine, but the girls have the freedom to come in at any time because the nurses are there, the trained, educated nurses. And we've also created a support group run by a psychologist and patients, and they are also available in that same location, which is the leading women's hospital. Okay, we've not got into a kind of a situation of we have developed a website, and it's just that it has to go into translation to the vernacular so that there is a greater outreach to people who do not know English or can communicate or express their problems better. But the fact is that the girls, once empowered, are quite capable of seeking our support at the appropriate times on their own rather than waiting for appointments, or it's a free kind of walk-in service.
And the other thing I think, so there you go, Chandrika in Sri Lanka can have a psychologist in her clinic, which is fantastic. The other thing we do, mainly actually for our South Asian population, is the mothers and mother-in-laws and extended family are able to come to the information sessions as well, because we find that makes it far more acceptable and useful. And if they're younger girls, their mothers are always there, are often interested in the features as well. So I think it sounds like the commonality is that all of us have nurses that may make it much more feasible to do a lot of the work.
I've had the opportunity to work with the Family Planning Association of India, and we ran an infertility clinic in South Mumbai for a very long time until the center shifted somewhere else. And then being a non-government organization, the funds were quite limited. So we didn't have the funds for doing ultrasound, HSGs, scopies, and blood tests, etc. So we tied up with some centers, and we said that we will provide you a good workload, but you tell us what is the discount at which our patients can avail of your facility. And then for blood tests, we tied up with a lab, and we said we'll collect the blood and we'll have the blood here, and you can send someone to pick up the samples, but will you give us a good discount on that so that our patients can then avail of this? And it worked very well while the clinic was working in South Mumbai and when I was in charge of that clinic. But in a public sector setting, you can tie up with private setups provided you give them a good workload and they can provide you the service at a discounted price then.
Okay, so just
I think the compliance also matters a lot. Compliance matters a lot because many times we see the patients who come to us. I have a counselor and a psychologist, so she talks to them, I talk to them. But when they need to go for lifestyle, they need to go to the dietitian or dermatologist. We take appointments for them. But then we see that half of the time they just don't go.
No, they don't.
They want everything at the same place, and which is not possible every time because all the patients probably do not come at the same time. So
it's
that
not
again
even
is a great issue. I mean,
I agree. And in fact, one of the things we found that when we analysed one of the initial clinics we set up was exactly that. But not even do they not want to come to the same place. If they have an appointment with the doctor, and the doctor says you really need to go and do this lifestyle because it's really important, they'll go. But if they have an appointment just with a dietitian, when they don't have an appointment with the doctor, the attendance rate is much lower. And we actually, between us, had a process where for 2 months, every time they saw a doctor, we emphasised the most important part of your treatment is going to see the dietitian, and really emphasised it and said don't come to see us until you've seen them. And the engagement was much, much higher. When it was just something that was offered as part of the service, most of them did not, well, a lot of them, but half of them didn't choose to go. So even in the same place, we have a challenge. But you can lead a horse to water, you can't make them drink. So if we can, we were just going to touch on briefly some research opportunities, and it's probably best if we talk to anyone who's interested afterwards in terms of more detail. But a couple of things that are worth saying is that we've all heard there's a lot of ethnic differences in this population, and you have a really large population. So without stating the obvious, one of the things that you can do is look at things at pace and scale. And we had an Aspire meeting many years ago, and I remember, I think that was the first time I met Chandrika, and we were sitting around, and I was very proud of the fact that we just published a paper in JCM with 430 people, and it was one of the biggest published cohorts. And I'm not kidding, I still remember Chandrika opened her laptop and said, "Oh, we've just done something like that in our local area." And I said, "Oh, how many patients?" And she said something like 10,000 and something. And it wasn't published, it was just on a laptop. And the Professor Chen from China was sitting next to her, and she opened her laptop and she had 100,000. And I remember just being, remember thinking, really, if we work together, you can do things at such pace and scale that we can't do. And in some ways answer really important questions. 60% of the world's population is Asian. And so often all the research is done in Caucasian populations, especially in PCOS. It would be really good to do some cross-sectional evaluation. But one of the most important things is it's ideally best done in the community, not in the patients that come and see you, because they're a very select population. So when we were here last time, many of you had presentations and research, but it was mainly your own clinic populations. And that's useful, but actually probably more importantly getting out to the community through any of the community centres and looking at that. And so the really big gaps are the natural history of menstrual cycles. One would think we know what the natural history of menstrual cycles is in adolescence, but we don't. There's one set of data that looked at Sri Lankan women compared to women around the world in 1968, and that's how far back we're looking. But in terms of the current status with the BMI that we now see in the population, and I'm not talking about the age of menarche, I'm talking about the natural evolution of cycles to say when people might be appropriate to investigate for PCOS. That's been one of the poorest evidence gaps in the whole guideline process, and that's not expensive. It's not difficult, but looking at cross-sectional and longitudinal analysis of young women, and then probably again of women in their early 20s, when you can look at the metabolic abnormalities, would be really important. Do looking through your patient support group, but also potentially Foxy was involved in the health professionals survey we did. So we did have quite a few health professionals from India, but doing that survey at a bigger scale, potentially at your meeting, for example, would allow you to identify the knowledge gaps and things and the needs, and also to promote your education materials when you're using the surveys. So you could engage your patients, engage your health professionals, and then also look at their cross-sectional, characterising them in adolescence and in their young adulthood and following them up over time. For example, it would be really fantastic to know what the baseline prevalence of impaired glucose tolerance is, but more importantly, what the incidence of impaired glucose tolerance and diabetes is over time, because your incidence of type 2 diabetes after GDM is positively scary, and I don't think we know enough, including the NAFLD and other things that might be different. So then there's obviously opportunities around controlled trials like inositol. So there's a number of opportunities where they would be possible.
You might want to know what we do in Australia in terms of funding, because it's not a model that works for you, but just so you know how Helena and I operate. We've had university salaries, so our salaries are sorted out, and we then have to write a grant to our main granting body, and it's very, very competitive, and we then have to go through that process. And the reason we've got a Centre of Research Excellence is because we did a lot of thinking and planning, and we put in a very good document. We had to be interviewed, and we were given money for 5 years. So that's why we've got money to do a lot of what we're doing. Helena is very well connected with the Victorian government, and therefore understands the mechanisms of what they want for funding health. So her clinic has been set up with a lot of state government money. So these things may not operate in India, where you don't have that sort of tradition. So the next model is one that I see in China and Vietnam, where I work a lot with them. And these are public or private clinics that do huge numbers of patients, usually with IVF, but they see lots of reproductive patients. And they're highly motivated that they want their center to be promoted and to publish highly. And so they put in a lot of time, effort, and money from their IVF to subsidize research in PCOS. You don't, in India, have those sort of numbers in one clinic, and you don't have the institutions that are doing that. So the next model is one that I've seen in the Netherlands, and that's where there are a lot of public hospitals that are doing high-quality reproductive medicine. And the heads of those hospitals' gynecology departments get together and they decide that they want to do a research study together. So if somebody writes the protocol, they all agree that their patients with those conditions will go through that protocol, and they use the ordinary running expenses of their service to generate the income, to do the randomization, etc. So those are all the various models that I've seen around the place. But there's one further model, and that is where a bunch of very small clinics all contribute to a much bigger national, international process. And this happens a lot in obstetrics, where groups follow a protocol, say treatment for eclampsia or whatever, and that even though they contribute small numbers, the large number of clinics build up enough to get very high quality results. So I've been thinking, having come to India for many years, how you would best operate. You're clearly not going to, at the moment, get large sums of money from grants from the government, because that's not available. You don't have the big scale clinics that are doing thousands of patients. But you do have a lot of very competent clinicians who like each other. As far as I can see, most of you are friends and not enemies. And there's no reason why a group of you can't get together and say, look, nobody else in the world's ever going to do a study on this, inositol, cara-inositol. Let's get some advice and do a really high quality protocol, and we would be happy to put you in touch with people that can help you with that protocol. And then it just means that as part of your routine service, you each contribute cases to this, and it might be 50 clinics that put in numbers, and maybe you only put in 10 patients each, but if you do it properly, you're going to have a very good study. And once you have success and you publish this in Human Reproduction or even a better quality journal than that, you get excited and you say, this is great, we can do this, let's have another trial. And so you then start planning trials. And there are many things in India you can do that no one else can do. And you've just got the unique population, you've got the large numbers, and I think you've got the collegiality and friendship to be able to do it. But it needs somebody to stand up and say, I want to do this. And Helena and I are very happy to offer our services. We'd be very welcoming of anyone that you nominate to come to Australia, or we would we'd send somebody here who could help you with those sort of things. But the rest of the world is looking to India and saying, when are we going to see the big trials that we know they can do, but they're not doing? And I think part of national pride is that your medical service needs to start delivering evidence-based care for Indians, because you've got the skills, you've got the contacts and the relationships. It just needs a little bit of organization.
How many cases would you expect, if we want to have a good result, if you do the myo-inositol trial? What would be the number?
Well, it's hard to tell unless you'd have to sit down and say, if myo-inositol works compared to placebo, we would expect, say, a 20% improvement. And then it's very easy to work out a statistical thing. If, however, you want to say, is myo-inositol better than metformin, you may need very much bigger numbers. So I would recommend you do a study where you don't need so many numbers. So like myo-inositol versus placebo might be very easy to do, and you might not need many numbers for that.
Yeah, so I think we've already done the sample size for what you need. I just can't remember what it was. And the only other model I was going to suggest, because there is perhaps another model, and then we're actually using that at the moment. So I have a study of 2,000 women in India, Sri Lanka and Bangladesh at the moment, which is actually around lifestyle in women. We pick them up in pregnancy and postpartum for GDM. The problem that Chandrika has highlighted about them not coming back, we've got around the fact that when they come back, it's all about the baby's health, and we just happen to talk about the mothers as well. But that program was very useful for us because we had to work out how your health system worked, and we have good collaborators in each place. But the funding opportunities are there, so the Council of India now partners with a whole lot of groups, including the Australian National Health and Medical Research Council. And while most of the funding comes from outside, some comes from India. So the ability to apply for joint funding, and the UK has similar rounds, or joint funding with other countries is there. And they're often very big grants. So that grant is a $2.5 million grant for 2,000 people. And we don't need anything like that, but there is opportunities. Australia now has a specific partnership opportunity with India. And so there are opportunities to do that. But the inositol, the other model I was going to talk about is where you've got another large randomised control trial happening in another country. So there is a proposed inositol study in the UK. And if they want multiple centres, there's the opportunity for India to become one of the centres. What they do, or multiple centres, is they send their clinical trial nurses out to educate your nurses. They do a lot of training online, and then they actually do the recruitment within your centres. And the good thing about that is they're supported by a rigorous group of people who are doing a trial, and you become just one of the sites. And it's a good way to learn how to do those sorts of clinical trials. So being part of a multi-centre trial would probably be a good opportunity. And worst case scenario with that, if that doesn't work, ideally you'd use the identical protocol to the one that's being done in the UK, so that you can add to the volume, or you work with them and know what their protocol is and ask a slightly different question, but it's done together. So I don't think it's impossible. I think that there's one other comment I was going to make, sorry, I am still very jet lagged. The other model is just to highlight what Rob was saying. So if I can give you an example, and this is where you probably really can do something at very low cost. So Rob was talking about as part of your routine care. So to give you an example, we designed a trial for women who have a BMI of 35, and we have lots of them, who are pregnant, and who come to our public hospital. And what we said was there's no evidence that putting lifestyle into their management of pregnancy makes any difference. So we're going to randomly allocate them to this type of service or that type of service. There's no big trial, there's no funding on top of it. So the women who come to book at the hospital on Monday, Tuesday or Wednesday morning get allocated to Clinic X, which is called the Healthy Pregnancy Clinic. Most of them haven't caught on to the fact that everyone in that clinic is morbidly obese. Or if they come on Wednesday afternoon, Thursday or Friday, they get booked into any service for obstetrics in the hospital. And so they're actually being randomised, but it's not part of a large trial. They go into normal care in one, and we just have a health coach in that clinic, and we weigh them all and we educate them. And the others, they just provide normal care. And that is almost no cost. We just had a PhD student who was linked to, so one of the other things is you can have a PhD student with you who can be linked to centres internationally, so you get some co-supervision. That person can do most of the work and do the analysis of the data, and there's no extra tests, there's no extra coordination, you're already providing the care. So even amongst your clinics, you could say we're going to test X versus Y. If there's no evidence for one being better than the other, you can actually say, these clinics are going to do it this way and these clinics are going to do it this way. So there are opportunities, just as Rob said, to use routine care, but just to be coordinated.
Yeah. So if you're going to do a trial on inositols, just so that the patient need not spend, can we involve a company who's manufacturing inositols and tell them to make a placebo and an inositol?
Yes.
And probably we randomize it, so the cost to the patient is not there. And I think
so
if we have
cheap.
multi-centric
Yes.
clinics who are doing it, we would have a large number of patients.
Yeah. So we could help design the protocol, and then the staff would need to be trained. But the main problem is the placebos are often expensive. So I don't know what they're like in India, but getting a placebo made so it looks exactly like the drug is often really expensive. And then they have these, they're made out of sugar, but they have these ridiculous expiry things on them. And if you don't get to finish them all, you have separate batches. So there are logistic issues that we wouldn't have to deal with. We could get our nurses to go through with you. But essentially, if you ended up with about 300 or 400 in each group, which off the top of my head is roughly what you would need, and you had a very simple standard protocol, then often the most difficult thing is actually getting the placebos, because they're expensive, and then getting the protocol agreed between all of you so that then you could recruit people and have the nurses who are capable of doing it.
Actually, we did a very small study, wherein one of the companies provided the placebo. So the placebo was vitamin D, and the inositol was also having vitamin D. So half of the patients, they would randomize, we would tell them, and they would randomize and give us. We did, for the infertility patients, we did about 40 of them, and the obstetric patients who had conceived, wherein they gave, again, a placebo, and they looked at the blood levels. And at least in the infertility, the whatever 40 patients we did, we really didn't find much of a difference, except that the lipid levels did improve. But and in that 3 months period, we really did not induce ovulation, so we looked whether these patients ovulated on their own, and we found that there was no difference. But in the obstetric group, whatever they studied, I think they had 70 patients in the obstetric group, and what they found is that the incidence of GDM was less in the patients who received inositols as compared to the. So it was the company who made, So
one of the
there is a question again when you tell a company to make.
So the problem with the companies
don't we require ethical committee?
Absolutely.
Approvals. But do they give approvals for these kind of stuff?
Oh, absolutely. Yeah. So you definitely. So even the study I was talking about in routine care, you still get ethics approval, and that's absolutely fundamental.
This was after ethical approval itself.
So with the studies, I think the most important thing is, really, it's not worthwhile doing a study unless it's adequately powered, so you can have enough people. But actually bringing the question back that you just had then is, what's your primary endpoint? Are you wanting to prevent GDM? Are you wanting to prevent GDM progression to type 2 diabetes? Are you wanting to look at ovulation or pregnancy or live birth? What is the endpoint you want? Because depending, there's evidence it improves ovulation, but not necessarily in the Southeast Asian population, and not strong evidence. There's evidence that it has some metabolic effects. So what we usually do is we work out what the gap is, what we don't know. And the systematic review is already done, so we know what the gap is. And there's no data on live birth and not very much data on pregnancy. And so we know where all the gaps are. And then the next thing is to say, okay, well, if that's the gap and that's our focus, how many people would we need, just as Rob said? So you can do it, our statisticians could do that calculation. And then if you work out the primary question, then you can design the study protocol around it. The thing you would need is an experienced trial coordinator to do that, and that will take some funding. So that would be...
So can I suggest that what you need is a champion. You need someone from your society that's a champion. That could be one of two people. It could be one of the older gynecologists who is very happy that they've fulfilled their financial aspects of their career and wants to spend a bit of time getting things going in the country. Or alternatively, it could be a younger person whose career has only just started, who says, look, I'd like to be involved in some form of research, trials, whatever it is. Now, the younger person could actually be funded by pharma, because I think you'll find if you went to some of the pharma companies and said, we need 6 months support for this person to go to whatever city to learn, I'm sure that they would fund that. And then it may be that one of you towards the end of your career wants to be able to catalyze and support exercise like that. But I don't think it'll get anywhere until one or two of you put your hand up and say, This is really important. I want to do it. I'm prepared to be trained. I'm prepared to work.
You got your volunteer
We'll get it done. We'll get it done. I'm sure we will. We will find the right person, junior, senior, and
No,
I
that's
think
the
to the
reason,
organization.
because I'm associated with a journal, and so Dr. Siladitya, every time he told me you must come and you must attend epidemiology workshop because it's really good. I mean, it will help you improve your perspective. And actually, I spent quite a bit. I must have spent almost 5 Indian lakh rupees because the course itself was 2 lakh rupees when both of us from here, India, we went over there. I mean, nowadays the pharma companies really cannot sponsor because there's a lot of restriction which has come onto the pharma companies in India, wherein they cannot spend personally for any of the doctors. They can give us educational grants to the society. So I think it would be the society which then would have to sponsor.
My experience is that Indian clinicians are extremely creative at dealing with pharmaceutical companies.
The only problem that happens in our country is that everybody wants to be the first author, but they don't want to work for it. That is the biggest problem.
That's the same everywhere.
So then how do you deal with that?
So
if you could tell us something, then everybody will be all right.
So what we have is, we have an agreement.
They don't want to contribute.
No, but we have an agreement where the role of every person is determined from the outset, including the authorship. But the caveat is that this is their role, and when they fulfill that role, they get the authorship, and if they don't fulfill that role, they don't get the authorship. But we do all that right up front. So it's pretty clear that you don't get authorship because you're the head of the unit. In fact, you often need to get an acknowledgement if you don't do anything. So, and if you're a clinician, you just recruit cases, you don't get authorship either. But we have all that up front in an agreement.
Oh, can we have a sample of that? Please, because Duru, this is the biggest problem in India. All of us are, maybe Rani, tu bhi Rani types.
So Duru, if you email me, I'll send you one.
I think the difference is also, you are in a full-time position at a university, you're professor, head of department, etc. For us, most of us are private practitioners, and the difference is that we have full-time doctors. They work in government institutions, they work with universities. They do have access to funds if they put up a grant, and I'm sure they can do it. I don't know how much is published from there, I have no idea, but from the Institute for Research and Reproduction, their promotions depend on the amount of publications they put in. So for them, it's important. I don't know what the scene is with all the public institutions in the country. There are some which are very good, they publish a lot, but from the private sector, these are our little issues. Each one works in their little space. We try to work things. We send out surveys which don't get filled. Then we'll send it to 1,000 people. We may get 20 responses. It's something like that. But I'm sure we can do it. I think we'll get to it. Helena will get back.
The thing is, to do research, you've got to have experienced a research culture.
Yes.
And, often in your training you don't get that research culture. So the majority of our doctors don't really get that research culture. They're only interested in heading out and making money. But we do have some people who are highly motivated to have a research career. And they'll often sacrifice a lot to go overseas for 3 or 4 years to work under a really good team. And then they come back highly motivated to set up their own. And I may be a little bit critical of the gynecological community in India, but I don't see that happening very often among your younger people. Saying I'm prepared to make a sacrifice to go to work in a high quality research place somewhere because this is what drives me and I want to come back to India and make a difference. So,
actually, Dr. Guru, if you remember when I was a resident in Badia, all of us, we used to have at least 2 papers every 6 months presented. And I think all my bosses who were there, they were one of the, quite famous gynecologists. And all of us as residents, almost about 30 years back, it was compulsory for us that we had to have our papers. So I don't know now, because I don't know what's happening in Badia now, but at least during our time, it was compulsory for us.
Quality of research is different. That is the only difference. Like I talked to you about the guidelines that we published, and you said this is lacking in that. You told me that. So that is what it is basically. We are what we are, and in order to improve ourselves, I think we'll have to get together and do what you are telling us to do. That's the only difference between us and, we are doing it to the best of our ability, but probably it's not matching the international standard.
It doesn't need to match it straight up, but if you partner with groups, it's not hard to get it from here to here. And it's usually just about process rather than, but I agree with Rob, you need a champion, you need someone who's going to be the person who's going to do it, and you need a trained
lead.
Nurse who has done clinical trial work before. But the other thing is you don't have to do a randomised controlled trial. Observing your population would actually be really valuable, and any of you can do that when the protocol's set up. So observing them and getting the nurses in your clinics to do that is quite easy and very important.